Good morning, everyone. Can you hear me okay? Thumbs up? Okay,
Yes.
fantastic. Okay, thank you. Well, good morning, everybody. I will call to order our April 5th, 2023 meeting of the statewide Substance Use Response Working Group. And I ask that we have a roll call, please.
Chelsea Cheatham.
Present.
Dr. Dixon. Senator Doñate. Gina Flores O'Toole.
Here.
Attorney General Ford.
Here.
Senator Severs Gansert. Assemblywoman Hardy. Shayla Holmes.
Present.
Jeffrey Iverson. Jessica Johnson. Present. Lisa Lee.
Present.
Debbie Nadler.
Present. I'm just letting y'all know I have COVID, so I'm going to try to stay on as long as I can.
Sorry to hear
Okay,
that.
thank you.
Angela Nichols.
Present.
Christine Payson.
Present.
Eric Schoen.
Present.
Steve Shell.
Here.
Assemblywoman Thomas. Dr. Woodard. And Dr. Dixon.
Here.
Mr. Attorney General, we have a quorum.
Thanks, Emma. And thank everyone for being here. I'm going to ask if you're not speaking to please mute yourself. And with that, we will move on to the next agenda item, number 2, which is for public comment. Is there anyone for public comment? Debbie, go ahead.
Hey, so I just have one question. I had written to Emma. I asked her to forward everything to the committee. I thought it was really important with some of that money that we get a memorial for our children. After all, I know the lawsuit is about, I know what the lawsuit is about, but we can't forget all the kids we lost. And I thought if we had some kind of memorial that we could use some of that money for, but I was told that it was a conflict of interest in me asking. So just for the record, Joe Engel, Tin High, and my group paid for a memorial garden, and we put plaques up. So if anybody has a loved one that they want to add, we now have one. It's at Western Trails Park in Las Vegas. So if anybody wants to text me if they have a name to add, we have plaques. That's all.
All right, thanks so much, Debbie. Is there anyone else for public comment?
Giuseppe Mandel, there is no Hero and Heroines Foundation and Alternative Peer Group Las Vegas, and thank you for having me.
Thanks for being here, Giuseppe. Great to see you.
Great to see you, Attorney.
Anyone else? Thank you. Anyone else for public comment? Do we have anyone online or, okay, no one on the phone. Did we get in a written public comment? Okay, very well. Then I will move on. We'll close public comment and move on to agenda item number 3, which is review and approval of our minutes from January 11, 2023. Those minutes have been distributed, Vicki, already. And so I will entertain a motion, an appropriate motion from whoever wants to provide it.
This is Jeff Iverson. I'm sorry I'm a little bit late, and I will motion to approve.
Oh, thanks. Welcome, Jeff. Please note that Iverson has arrived. There's been a motion. Is there a second for approval?
This is Shayla Holmes. I'll make a second.
Very good. It's been properly moved and seconded that we approve the minutes from the January 11, 2023 SURG meeting. Any discussion on the motion? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Aye.
Aye.
Any opposed say nay. Any abstentions? Motion carries unanimously. Thanks so much. Okay, we'll move on now to the substance of our meeting. Agenda item number 4 with our harm reduction presentations. Our first will be, well, first off, let me remind everyone that we have allocated 5 minutes per presentation with 10 minutes for Q&A afterwards. So please keep that in mind. We will have a timer available to remind folks of that time frame. And with that, we will begin with our first, which discusses bad batch application. Lisa Lee and Alex Nay. The mic is yours.
Thank you, Chair Ford. I also wanted to include Madeline Larson, Maddie Larson. Alex is not available to speak today because they are in school, in high school. So good morning, everyone. We are just presenting on this awesome partnership, which is a bad batch alert application. And I will hand the floor to Maddie at this time.
Yes, thank you guys. I'm so excited to be here. So the Bad Batch app is being funded by the Overdose Data to Action OD2A, which is then funded by the Centers for Disease Control and Prevention. Next slide, please. So the proposed name of this Bad Batch Alert app is the Safety Outreach System, or SOS. And it's an app that will alert its users of instances of overdoses or positive fentanyl test strip positivity within a geographic region. This information is collected from users of the app through allowing them to input this type of event, overdose or positive fentanyl test strip positivity. When that happens, and then their zip code that's associated with that event. So other than that, they will remain completely anonymous, which is really awesome. So we will only ask for their zip code information to then alert other people in that geographic region. So for example, when there's an instance of this, someone would report it on the app, and then the Northern Nevada Harm Reduction Alliance will be monitoring the app to then send out push notifications to its users to really encourage them to test their drugs and to use harm reduction modalities. Next slide, please. So the issues that are really pushing for the reasons why we want to have this app is because of the high overdose rates in Nevada, and also because of the increasing adulterants that are in the drug supply. So we all know about fentanyl, and then we have carfentanil, which is even higher than fentanyl, and a bunch of other things that are even hard to say, like nitazenes, bromphene. We've been talking a lot about xylazine, which is a non-opioid thing that is being cut with fentanyl. And so Narcan can't even reverse xylazine because it's non-opioid, but it's really contributing to a lot of our overdoses, as well as tinopatine and levamisole and other ones that they're creating. Next slide, thank you. And then this app is really hitting on a lot of different populations: veterans, elderly persons and youth, pregnant people and parents of dependent children, the LGBTQ+ community, people who inject drugs, and also other populations that are disproportionately impacted by substance use conditions. And now I will hand it off to Lisa to finish it off. Thank you, guys.
Thank you, everyone. Lisa Lee for the record. This project is it's actually my 16-year-old, so I'm going to do a mom brag right now. My 16-year-old child, whose pronouns are they and them, Alex, is working, is in the medical academy at AACT, which is one of the signature academies here at Washoe County School District. And in that medical academy, all juniors are required to do a junior service learning project across academies. So there's a business academy, there's agricultural and veterinary sciences, et cetera, et cetera. There's a whole bunch of different academies. And so this was really created by students. And in addition, it is based on an application from Ohio called the SOAR app, which was also created by college students, not high school students. And so this app, there's screenshots here. You're all free to download the app as well. It is available in the Apple Store and the Google Play Store. Similarly, this Bad Batch application will also be available in both of those stores for smartphone users. You download the application. If you're curious, like I was, you can download this, and these are screenshots of kind of what you see as an end user. So the first one on the left talks about how this works and what information is or is not collected. Users are able to opt in, as you see in the next screenshot there. They can opt in to receive those bad batch alerts. So it's not just automatically spamming people. They have to have an opt-in consent process. And then there's a little notification that pops up that says, I understand that the data I submit will only be used to alert my community of possibly dangerous batches and will not be connected to my personal information. Then they give you a little disclosure about how your information is used. And then the next one shows kind of, you can also hit the button that says bad batch alerts, and you can see kind of a historical account of those push notifications that have gone out to community members. In Ohio, the way they have it arranged is you pick your region. There are 11 regions that it's broken down into for Ohio. So you're not getting alerts from across the state. You're really getting those regional alerts. Similarly, this app could correlate to those behavioral health, the regional behavioral health areas, which would really be great to notify our partners across those behavioral health districts. And then there's also a way to link to get free supplies, which could be linked to NV overdose response. Next slide, please.
Lisa, we've reached the 5-minute time period here. So why don't we commend to the reading of the rest of our committee members the remaining slides here, talking about gaps and recommendations, but sure. Let's offer an opportunity for people to ask questions as of now.
Okay, perfect.
Are there any questions from the group? If there are no, okay, we have a couple here. I see Eric's question, Eric's hand up, and then Debbie's hand. Go ahead, Eric.
Yeah, thank you, Attorney General. So Lisa, this is pretty exciting. What kind of utilization are you guys seeing in Ohio?
I don't know about their utilization. They don't post that information on any of their sites as far as utilization.
Okay, thank you.
Thanks, Eric, for the question. Debbie, did I see your hand come up?
Yeah, for some reason it keeps going on and off. Lisa, this is a great thing. My question to ask you is, are we able to, and maybe you said it, are we able to see what's going on in Nevada through this SURG app? Does it break down into different areas, or is this nationwide?
Thank you for your question, Lisa Lee, for the record. This would be a Nevada application that these high school students are working on in partnership with the Northern Nevada Harm Reduction Alliance. So the goal is to pilot in Northern Nevada, and then if the behavioral health regions are interested in also coming online after we, work out kind of the bugs, then we could expand across the state. So this would be a solely Nevada application for Nevadans that would not only benefit people who use drugs, but also those of us working in public health and harm reduction to alert us of potential spikes so that we can deploy resources into communities and make sure that we're really hitting those targeted regions.
This is great. I wish we could get it in Southern Nevada. Are you pushing to do that?
There has been discussion. Thank you for the question, Lisa Lee, for the record. There has been discussion with our partners in Southern Nevada, more to be revealed as we kind of move forward with this process.
Thank you. This is a great thing. Thank you.
Yeah, Lisa, I'm intrigued by this. It seems like a very good idea. I wonder if there's an opportunity for those developing the app and things of this sort to make inquiry with the municipalities that are getting opioid settlement monies to ascertain whether there are opportunities for grants or financial support to help facilitate the development of this app. that's not really a question, just kind of thinking out loud, reminding folks that that's the purpose of the settlement money that we're bringing in, is to look for opportunities to abate the opioid crisis. And while this Bad Batch app probably speaks, it could speak to more than just opioids, it certainly could relate to what it is we're talking about in the opioid context. So great work on that. I think. Any other questions from the group?
Yeah, we have comment question in Vegas.
Okay, please go ahead. State your name for the record,
Hi.
please.
Yeah, Jessica Johnson for the record. Lisa's so excited to see this Bad Batch app coming to life here in Nevada. 2 questions. One, is there opportunity in the app to expand just beyond inputting fentanyl test strips, given the additional adulterants that Maddie mentioned? And 2, I would like to recommend this presentation for the next meeting of the cross-sector task force, if appropriate. I think this is a great example of a shorter term intervention that could have big implications. Thank you.
Thank you, Jessica. Lisa Lee for the record. I'm sorry, I totally spaced your first question you asked. You said, is there room to add other drug types given the amount of adulterants found across illicit substances? Is that what you were asking?
Yeah, Jessica Johnson for the record, correct. Like BTNX is coming out with, I think it's like a xylazine test strip. So I'm just wondering if, as we're seeing these novel adulterants come on and the opportunity to assess if they're in the drug supply with some of like a fentanyl test strip like product, if that's in the broader vision of that.
Yes, thank you for your question, Lisa Lee for the record. That is, so the way they're building out those drop downs, once the CDC, there's some purchasing issues right now, but once that application builder is paid for, the students are going to begin working on what that looks like. And the goal is to have, from what I understand, drop down menus, so showing which drug or drug types, so you can select multiple, were tested or involved in an overdose, whether that's non-fatal or fatal. So you can kind of pick, like, were you testing your drugs? Was there an overdose involved? What substances were on board and what adulterants were on board? That is the information that is collected, in addition to a zip code narrowing it down. Because, I mean, you don't want to be too invasive with like street name or anything like that, but just the zip code or general area. And then it does have an opportunity, as we bring quantitative drug checking on board, to also be able to integrate some data into the system to be able to push out those notifications to people who use drugs, because that's who's dying, right? And there's no publicly facing dashboards to really serve the community whose lives are at risk.
Thank you.
Great presentation, Lisa, and thank you so much, Madeline, as well. Any final questions before we move on to the next presentation? All right, hearing and seeing, I see we have a couple of comments in the chat. Are those for us or are we good?
There's no comment in the chat.
Oh, okay. Okay, very good. Well, thank you so much, Lisa and Madeline. Appreciate the presentation. We will move on then to the next presentation, which is going to be presented by Ivy with addressing quantitative drug checking for people who use drugs. Ivy, mic's yours.
What's up, y'all? I'm Ivy. I work at Tapestry Health, which is a place in Western Massachusetts. I work with Jeff Tilley as part of the New England Users Union. I'm going to be talking about our drug checking initiative, which is based out of MADS, which is the Massachusetts Drugs Data Stream. Yeah, I'm gonna go to the, thank you. Yeah, so that says all that. Drug supply data stream, that's the acronym. So what we do is, it's technically drug supply surveillance. because it's not quite real-time drug checking. Real-time drug checking would be people bring us samples of their drugs, we test it on the spot and give them the results before they use them. So we're doing what is called drug trash checking. So it has to be kind of discarded drug supplies, so the ends of bags or used cookers, stuff like that. Any discarded drug material. We use a combination of FTIR mass spectrometry. So this is a type of spectrometry that uses infrared light to measure absorbance levels. It's really good because it's relatively low cost compared to other types of drug checking, and can break down the components of a drug sample in a bit more depth than just a fentanyl test strip. We do pair this with fentanyl test strips and with benzo test strips. The fentanyl test strips have a much lower threshold of detection, so they're able to make a positive ID for fentanyl if we can't necessarily see it on the FTIR, because the FTIR does have a limit of detection around 5% of the composition of the bag. We then send all of that off to a lab. My site sends it off to CFSRE, other sites send it to drugs data. Those places use GCMS testing, or gas chromatography mass spectrometry, which is much more sensitive type of test. It can see drugs in much lower composition, much lower component ratios. It is much more expensive. It's around $100 to $150 per sample. So that is one of the limits with that. But pairing those three technologies together is very, very effective. Yeah, so now you can go to the next one. That's good. And so the quantitative drug checking is done by the GCMS. We can't really do quantitative drug checking with the FTIR that's qualitative, although there are ways to kind of estimate or make an approximate, understand the approximate amount of the drug within the bag, even though it's more of an estimate. Yeah, the issues that we're addressing, right, the drug supply is incredibly unstable. 1 week we'll be getting bags that have like 3% fentanyl, the next week we'll be getting bags that have 20% fentanyl. So this is really seeking to address the instability of the drug supply. There's also crazy cuts that are coming in now. We've been talking about xylazine. Xylazine was showing up in pockets, and now it's pretty much fully infiltrated our drug supply. Levamisole, which was mentioned previously, that's the main one in coke that we're seeing these days. That one, levamisole and xylazine, in addition to changing the effects of the drug when you're using it, they both have some pretty gnarly long-term health effects. Xylazine is a vasoconstriction and clogs, and also raises your glycemic index, so it can lead to kind of diabetes-like symptoms, and then also creates a lot of wounds. Levamisole does a similar thing, different mechanisms, but it also leads to some pretty gnarly wounds. And then we're also seeing an increase in synthetic opioids across the board. So that was mentioned with the nitazines. There's other non-fentanyl based synthetic opioids, and they're just really popping up more and more frequently. Kind of as they're getting scheduled, and as certain ones are getting scheduled, new ones pop up to replace the ones that were just scheduled. And all of this has a really severe impact on overdoses and long-term health effects. You can go, yeah. Mostly the people I work with are, and mostly the people that Mads works with is people who inject drugs, but we're also working with people who inhale and sniff, and working with people who are selling drugs. Well, so the the key part of what we're able to do right now is we're able to kind of monitor how the drug supply has been changing over time, as well as get a bigger picture of the drug supply in our region. So like I said, I'm based out of Western Massachusetts, but this study MADS is throughout Massachusetts, and then also they get some data from Connecticut and Rhode Island as well. We've been able to see how xylazine has increased over time. We've been able to see how much levamisol is in it, and we're able to communicate what the drug supply looks like to the people who we're working with, to the people that come. I work in a SURG exchange, so like when people come into the SURG exchange, I'm able to have conversations with them about like how the drugs have been affecting them, how they feel, and then we've been able to talk about like, oh, like that those adverse effects might be like a risk, might be something to do with like the xylazine in it, or there might be levamisol in the coke that you're shooting. Like bring in the end of the bag and we can test it and figure out like what is going on for you. And I think people are starting to really take this service much more seriously. And yeah, it's been helping to create a lot more dialogue about the potential cuts in drugs.
Ivy, we've reached the 5-minute mark, but I'd like to jump to the last, or second to last, or maybe third to last one with the recommendations real quickly. You can discuss recommendations, and let's open it up to discussion and questions for that. So Ivy, if you want to go ahead and go talk about the recommendations, that'd be great.
Word, yeah. So one of the setbacks for drug checking is that it's a gray area. So you have to get special, you have to have a special agreement with whatever local municipal police department you're working with, and you need to have like a board, like works well to work with the board of health. So if you are trying to implement drug checking, you should be working with existing harm reduction organizations that already have community connections. You should identify places, cities, municipalities that already have harm reduction leaning ideologies within their government and their police departments, and the ones who would be most likely to condone this type of gray area intervention. Yeah, those are really my, does that make sense? Do you have more questions on that?
Absolutely, Ivy, and thank you for prompting the discussion on this and these recommendations. Let's open it up for questions from the committee. Any questions?
We have a question
Debbie?
in Las Vegas.
Okay, and then we'll go to Las Vegas. Let's go to Debbie for now.
Hey, sorry about that. Thank you for that presentation. Is this something that's being done with hospitals too? We're getting the information or no?
The majority of this information is coming directly from people who use drugs. There are some things we'll get. Sometimes like police departments will notify us of some drugs. Sometimes the occasional like detox will give us some samples, but pretty much the majority, I would say like, yeah, almost exclusively it's coming directly from people who are using drugs.
Thank you.
Implement this with a hospital. So.
Thank you, Debbie, and thanks for the response, Ivy. We had a question in Vegas.
Yeah, thank you, Attorney General, for Jessica Johnson for the record. Ivy, fantastic presentation, really interesting to hear what's going on in Massachusetts with your drug checking efforts. Thank you for sharing about them with our committee today. I had two questions. One, could you talk about what funding you're receiving? It sounded like the additional testing did have a cost burden to it. So I was wondering if you could share about that. And then is your team developing resources for other harm reduction groups or local health departments based on what you're seeing from these results? Thank you.
Yeah, so all of the funding for this project, MADS, is all funded through primarily through BSAS and also various grants. It is project through Brandeis. I think we kind of went over it really quickly, but so it's a Brandeis University. They have like the opioid policy research, whatever. So that is where the project originated from, and they have various funding sources as well as the Massachusetts Department of Public Health and BSAS, and then outside grants as well. That's kind of above my pay grade. I'm just kind of the person that works with the actual machine and works with people who use drugs. And as for the second part of your question, Brandeis has also been developing a great website called, I think it's called Street Check. So all of the results that we get, along with all of the various other drug checking sites, they all upload photos of the drug and the qualitative results that we get from the FTIR and the fentanyl strips. And then when the quantitative results come from the lab, they're also added to that. So you can see all of the different samples that have been tested. So it's in the thousands right now. I know I've personally tested like 150 samples in the past 6 months. So all of that information is, you can see the results. Anyone can access the site and see the results. And they also have kind of live statistics and models and breakdowns of all the different trends. And so that's all public facing.
Thank you.
Would you mind, I'm so sorry, would you mind putting a link to that? Do you have a link to that where we could find it? The Brandeis?
Yeah, it's all in the last, the resources, yeah.
It's on the last slide. That was Debbie Nadler for the record, but it's on the last slide though, Debbie.
Okay, thank you.
Ivy, this is Terry Kearns here in Las Vegas. I had one last question. You may have said this in your presentation, and I may have missed it, so my apologies if I did. The lab that does your quantitative testing, is that a private lab? Is that a state lab? Or what type of lab is it that's doing that quantitative testing for you?
So there's two different labs. So there's drugs data, which is a private lab. That's the Arrowhead drug checking lab. And then there's CFSRE, which is some acronym for, it's like I think it's also a private lab. It's based out of Philly. It's a forensics research lab.
Yeah, I'm familiar with that lab.
I'm sorry, what was that?
I'm familiar with that lab. Thank you.
Yeah. Center for Forensic Science Research and Education. So yeah, those are our two labs.
Thank you.
Mm-hmm.
All right, thanks. Any other questions before we move on to the next presentation? All right. Well, thank you so much. Speaking of drug checking for people who use drugs, we're going to turn to Nevada now with Marco Mendez. Marco, please proceed.
Thank you, Attorney General Ford. Good morning, everybody. So similar to Ivy's presentation, I will be discussing surveillance of the illicit drug supply and how we've been implementing that here in Southern Nevada so far. And then recommendations for how we can continue implementing that on a statewide level. If we could go to the next slide, please. Just a disclosure here, this project is supported similar to others by Overdose Data to Action Grant through CDC. So any of the views expressed here are not necessarily those of the US government, the CDC, or Southern Nevada Health District. If we could advance the slide, please. All right, so a quick introduction, just to help underscore what others have already mentioned. Oh, I'm sorry, it looks like the timer is up.
Crystal, we can't see the presentation, thank you. If you could go back to the presentation. I would go ahead and continue, Marco.
Thank you. So surveillance of our illicit drug supply is very important. It helps us save lives and helps prevent unintentional fatal overdoses in our community. So speaking specifically for Clark County, where Las Vegas is housed, we have seen 2,101 unintentional opioid-related deaths over the past 7 years, so from 2015 to 2022. And that is 88% of all opioid-related deaths. So the remaining 12% were intentional. based off of a statewide report through our state overdose data action team, nearly 40% of our opioid overdose deaths involved methamphetamine, and nearly 30% of stimulant overdose deaths involve fentanyl. So this sort of approaches the issue of polysubstance use, as well as adulterants that are cut into various substances that people use. Next slide, please. So we have our emergent issue. Again, this is national and in Nevada. Adulterants present in substances that people are consuming may increase the risk of death or other lethal complications, such as the wound healing complications that may arise from xylazine, or the cardiovascular suppressant effects of strong opioids such as fentanyl. So people who purchase and consume illicit substances may be consuming other substances that they're unaware of at the time of purchase. They may think that they are purchasing a bag of heroin. It may actually be cut with fentanyl, among other substances. Next slide, please. So special populations that these sort of initiatives should target: people who inject drugs, but also those who consume drugs by other means. So that could be snorting, smoking, etc. And then other populations who are disproportionately impacted by substance use conditions, such as the LGBTQIA+ community, children and youth involved in the child welfare system, and then our BIPOC community, our Black, African American, Hispanic, Indigenous, and other persons of color. But of course, drug use and substance use disorders can affect anyone of any population group. And that's important to underscore. Thank you. So what we have been doing is fairly complementary to what Ivy discussed earlier. So we've had an ongoing effort of surveillance of our local illicit drug supply. This started out using a portable mass spectrometer in partnership with our local syringe exchange. And then we expanded that to include test strips for comparison. And then more recently, we have partnered with the National Institute for Standards and Technology, NIST, who's able to conduct high sensitivity lab-based spectrometry of samples taken from our local syringe exchange. So Ivy discussed quantitative drug checking for surveillance. This approaches the qualitative version of that. So we're not able so far to get quantities exactly of each substance in a sample. However, we are able to tell what substances are in that sample. With our current partnership, we're able to detect up to 10 substances per sample, based on whatever may be cut into the substance that the person submitted. Other things that are working well, however, here are expanded harm reduction education and practices. We have a robust program for training on administration of naloxone using fentanyl test strips. We've been distributing both of those things throughout the community, and then helped increase access to harm reduction supplies, examples of which are listed here, but that's through our public health vending initiative that my colleagues have helped to stand up here in Southern Nevada. Next slide, please. Some gaps. I think speaking specifically for the state of Nevada, I think so far, from my understanding, public health surveillance isn't standardized as far as illicit substances, especially at a state level. And I think another gap that we face is increasing the accessibility of drug checking methods for community level harm reduction, such as field testing of substances prior to use. I'm not fully versed in any legal barriers that may come with that, but it's definitely a gap, I think, statewide. Next slide, please. So recommendations. I would recommend widespread, routine, reportable testing of emergency department patients, This would be for commonly used illicit substances or licit ones, and then commonly seen adulterants for public health surveillance purposes, as well as state and or regional labs with capacity to test these substances with high throughput and sensitivity, sort of like our partnership we have with the NIST lab currently here in Southern Nevada. This would allow all of the samples to stay within the state and then allow for synergy with other harm reduction activities. Off the cuff here, I would say this could synergize well with the SOS app that was discussed earlier to help the community be aware of what may be in local drug supplies across the state of Nevada. I would also recommend accessible sites for community members to submit their substances or samples for rapid testing and reporting, again, for that state level public health surveillance of illicit substances. Next slide, please. So for everyone's reference, I've included these 3 peer-reviewed publications for additional information on qualitative drug checking and the adulteration of substances in the US.
Thank you, Marco. We appreciate the presentation there. Let's open it up for questions now. Any questions from the committee? I have a question, Marco. This conversation around quantitative, and this is probably for Ivy as well, but certainly it's a Nevada specific question about quantitative versus qualitative testing of drugs. This conversation has come up in the context of fentanyl-based legislation that's been contemplated here in the legislature right now. And the question of whether our labs are capable of doing quantitative assessments of drugs to ascertain what amount of fentanyl, for example, is contained in as an adulterant in drugs. Can you tell me from your perspective why we aren't able to, or maybe I'm presuming, but are we not able to do quantitative testing in Nevada? And if so, what's your perspective on what we can do on going forward to fix that?
Thank you for your question, Attorney General. From my understanding, and I'm not sure how up to date this is, but from my understanding, our current state labs, I know we have the Southern Nevada and the Northern Nevada lab. From my current understanding, they're not able to conduct this kind of high throughput testing at the current time. So I think my recommendation would be perhaps expanded funding and training for these labs to have the capacity to perform this kind of sample testing.
Okay, I appreciate the response. Yeah, that's good to know. Like I said, this conversation is quite apropos relative to the legislative session right now because there are questions related to quantitative versus qualitative in the fentanyl bills. Lisa, and then Debbie.
Thank you, Lisa Lee, for the record. I just wanted to respond to that. I know in the Northern Public Health Lab, they do have a mass spectrometer. Elise Monroy was able to find them the funding to purchase the equipment. The last update I received was that they were awaiting a table for this mass spec to sit on. And the question then is, who pays for the samples, right? I mean, who pays for like the staffing to run the samples? So there's some logistics to work out to be able to offer this to the public. This would be for public health, though. I want to point that out. It was made very clear to me that this is for public health, not law enforcement to use. So I just wanted to provide that update, and I may be missing the most recent updates, but that's the last I heard as about, I don't know, 2.5 weeks ago.
Thank you, Lisa.
Okay, let me be sure to understand what you just said, Lisa. So am I understanding you correctly to say that this device, to the extent law enforcement wants to use it to determine how much fentanyl is in an adulterated opioid, law enforcement would not have access to that device in order to figure that out? Is that what you're saying?
Lisa Lee, for the record, that is correct. This is for public health, to really keep people safe, not to further criminalize people who use drugs that are bringing their samples in for testing.
Sure. Yeah, let me qualify the statement, because my understanding is that law enforcement would endeavor to use this to ensure that appropriate charges are effected, as opposed to the qualitative approach, which says that if you have something that's 4 grams, all of it is presumed as 4 grams. But if you could use this device to only show that 1 gram is there, then only 1 gram would be that which is at issue. Do you see what I'm saying, Lisa?
Yes, Lisa Lee for the record. I would suggest in that case that the forensic lab or whomever law enforcement currently uses invests in quantitative testing, so that people, like, say I had 4 grams of sugar in my pocket and it had trace amounts of fentanyl, and you put me in prison for 4 grams of sugar, basically with trace amounts of fentanyl, saying that I had 4
Right.
grams of fentanyl. I would suggest that the state forensic labs also invest in mass spectrometry so that they can do quantitative testing, rather than just use that qualitative methodology. But I think we're talking about 2 things here. We're talking about public health and harm reduction, and then we're talking about criminalization of substance use, which I think are very divergent methods of what we're doing here. Thank you.
Okay, very well. Thanks so much. Okay, Debbie was next, and then I see Ivy's hand up.
Lisa kind of touched base on what I was going to talk about. Thank you. That was it. Thank you.
Thanks, Debbie. Ivy, go ahead.
Yeah, I was just wondering, what sort of portable drug checking device are you using currently for this initiative?
So our local syringe exchange uses a MX908 portable mass spectrometer, is what we've been using. However, the partnership we have with the NIST lab is not portable method, so they use DART MS. Very specific kind of mass spectrometry that requires little adjustments to pressurization of the samples, as well as sample dilution, things like that. So that's been much higher sensitivity. It's shown us better qualitative results. And the turnaround time is pretty quick, despite us having to ship the samples. In theory, in a week, somebody could submit a sample, it could make it to the lab, and we could have results back by the end of that same week, theoretically.
Cool. Thank you.
All right, any other questions of Marco before we move on to the next presentation? Very helpful, Marco. Thank you so much for your presentation, sir.
Thank you.
All right, next up we have harm reduction supply shipping efforts to be presented by Kat Wright. Go ahead, Kat.
Hello, thank you for inviting me to speak today. So I am one of the managers at the local syringe exchange that Marco mentioned in his presentation. We have 2 sides to our company. We have Track B and we have Impact Exchange. Full disclosure, we are not without bias when it comes to providing harm reduction supplies to the residents of Nevada. The main one that you would want to focus on with this would be that we do receive some funding to support a mail program to distribute naloxone. It is not fully funded, but we do receive funding for these particular efforts. Next slide, please. Okay, so we actually do have 2 sides to our shipping program. One is where someone actually reaches out to Next Distro, which is a website that they can enter their information into to find supplies, whether it's harm reduction supplies or naloxone, close to them, and it will actually give them that information depending on what their state is and any restrictions that were placed by those organizations in terms of how far away they're willing to ship. Some of them do have radius limits where you have to be further out before they will ship to you. So we get most of our shipping clients through them. Most of our clients are focused on naloxone with that. We do always provide naloxone no matter what they ask for. The other way that our shipping program works is that someone can actually contact us directly by text. We have a phone line specifically for that. And then that way they can just give us the very basic information needed to ship something to them and request whatever they would like. Both of these situations are not perfectly anonymous because we do have this person's address, but we do function with usernames so that we don't have personal information for anyone that's receiving these items. That is something that we try to maintain as much as possible to avoid stigma and to help ensure that people do feel comfortable using these services and that they are not going to face judgment because something is associated with them. The primary purpose for these shipping programs, no matter how someone reaches out to us, is to provide naloxone. We do have 2 types, and we do always focus on someone receiving that regardless of what other supplies they request. So the 2 types of naloxone we provide are nasal, which also goes by the brand name for Narcan. And then we do have intramuscular naloxone, which we provide the syringes to go with that for injecting that. Next slide, please. So our main focuses with this program are primarily to counter opioid overdoses and get the naloxone out to the community. The secondary one from that is providing additional harm reduction supplies, especially to people who would not have access to them if they live in an area that does not have syringe exchange services, which pretty much means anywhere in Nevada outside of Reno and Las Vegas, or Elko. Technically, we do have exchange in Elko, and it also is very helpful for people that potentially can't access those exchanges, even if they do live in those towns. So the biggest thing for us supplying the additional harm reduction supplies is that it does help prevent opioid overdose deaths, because some of the supplies that we provide besides naloxone are fentanyl test strips. We're also helping make sure that people have clean items to use, so there's not a risk of sharing or risk of reusing anything, which does help prevent infections. And then this is also where we take an opportunity, especially if people request additional information from us, to provide them with information about connecting them to other services they might be interested in. That's included things such as medicated assisted treatment for drug use that also can be helping get them into detox facilities. And there's pretty much anything that they would ask us for. If we have that information available, we will provide it to them. Those are probably the 2 most common things that would be requested of us, though. Next slide, please. Thank you. So the primary focus of this would be people who inject drugs. That being said, our items can be used by pretty much anyone who injects substances, and we do have clients who do not use illicit substances, and they simply do not have the resources to obtain clean syringes in their area. The cost of clean syringes from a pharmacy is rather prohibitive. And that is something that we have run into in some areas where the cost has gone up to a point where we have gained new clients simply because of those cost increases. So that is something that would affect potentially anyone who has diabetes, but we do also provide the syringes needed for people who use who inject other medicines and are using hormone therapy. We do provide supplies for those as well. So pretty much the main focus is people who inject drugs, but this does help other people as well. So I gave the breakdown here of how many packages we shipped out in 2022. So as you can see, like compared to the size of the state, obviously this is not a very, very large number, but we only ship 1 package out per month per client. We ship out enough supplies that it should cover them for an entire month. So if this were something that we're like going out more frequently, you would see a much higher amount for this. As you can see with these numbers, the majority of our orders are placed through Next Distro, and it is definitely more streamlined, and there is much better tracking for the situation when they place them through that. So that is definitely our preference. We do also have some peers that work for our organizations that are able to request items for their clients directly that we can ship out to them. And when we do that, we do tend to ship larger amounts in bulk. The counties they're located in are Mineral, Humboldt, and Elko. Specifically, they are in Hawthorne, Winnemucca, and Elko. And below that, we also have all of the counties where items were shipped to in 2022. As you can see, this is not all of the counties in Nevada. We do think that there is an issue with people in the other counties being aware of the fact that the shipping program exists. It is definitely something that we found is mostly word of mouth that people know about this and utilize it. That said, this is not an expensive thing to do. The shipping for these is typically less than $10 per package. It is based off of weight. And we, when we're supplying an entire month's worth of supplies, that still is less than $15 per person. If someone requests less than that, it becomes even less. But for me to supply someone for an entire week would be less than $7. When it's something where I'm able to bulk it this way, that helps with the cost as well. So it's not an expensive program to fund. Next slide, please. Thank you.
Hey, Kat, we've actually gone beyond the 5 minutes. I'll come in the gaps to the folks, but that's fine. Can you move on to your recommendations though, and then we'll open it up to questions after that.
So this is something that I do think if a program like this were to be funded anywhere, there are certain gaps that we've run into that I think would be something that would be an issue for any other program as well. And a big one with that is returns. Consideration needs to be made for not just how to get supplies to them, but how to receive them for war destruction. And that I think would be the first thing that anyone needs to think of after they decide if they're going to fund a program like this. For Nevada, the place that would make the most sense for those returns to go is Reno and Las Vegas. They're very large and there's multiple options for destruction there. Beyond that, educating people more about the alternative options for naloxone is a very big one. We definitely run into a lot of resistance with people wanting to use intramuscular rather than nasal because it's been promoted to them that nasal is easier to use and there's misconceptions that it's more effective. And that does make it very hard to sustain a program like this because of the cost of nasal naloxone. So that note there of that ratio of 1 to 10 versus 40 to 50, that's the cost of a dose. Right now, getting a dose of intramuscular naloxone only costs me $1. That's not a permanent cost. That's something that's part of a nationwide program that's benefiting syringe exchanges. The normal cost for that would be closer to $10, but the cost of a single dose of nasal naloxone is $40 to $50. So when I send them a box, I'm sending them $100 versus what I can send them for the cost of 3. Does anyone have any questions?
Go ahead, Kat. Oh, okay. Well, thanks so much, Kat. We appreciate that. Let's go ahead and open it up for questions. I do see Debbie's hand up. Go ahead, Debbie.
Hey, thank you so much. I'm sorry to ask so many questions and I might be unknowledgeable on this, but can anybody order? Do you have to be certified? Can parents who have children suffering order? I see a lot of, I'm in groups with a lot of moms who are trying to get Narcan and they can't get them. And the second part is I see in many states, the supply of Narcan is extremely low. What's going on in our state?
So for being able to order the naloxone, because we do focus on keeping this anonymous as much as possible, we don't really place restrictions on who can be ordering. There is a vetting process that people go through with Next Distro, but outside of that, we are not really able to ascertain if this person is ordering for themselves or ordering for a family member. And we basically take the route of it's better for the community to have it regardless, particularly when it comes to saturating the community with naloxone. when it comes to the availability of the different types of naloxone, I can't speak for the entirety of Nevada, but speaking from what I've run into in Southern Nevada, the different organizations that had access to support and funding to help provide them with naloxone has run out for a lot of them. And there's fewer of us that are basically able to distribute it without it being at a high cost for us. I currently get nasal naloxone from the state, and then we purchase intramuscular naloxone. And that's something that is not available for other organizations currently to do. I know that the health district is also able to get nasal naloxone, but as demand has increased on those of us that still have it, it's much harder for us to keep up with that demand. Speaking for the syringe exchange, that becomes doubly difficult because we have to prioritize being able to make sure our clients have it, rather than distributing specifically to different organizations or offices that would like to have it on hand, because we do know that the vast majority of opioid overdose reversals are going to happen by someone who also is there who uses drugs, rather than someone having to overdose in a handy place near a an office that happens to have it stashed in a desk drawer.
Okay, thank you.
Thanks,
you.
Kat. Other questions?
We have a question in Vegas.
Go ahead.
Hi, thank you, Attorney General Fuller, Jessica Johnson for the record. Kat, excellent presentation. Thank you for sharing more about the shipping program. I just had two quick comments. One, I would like to recommend the shipping program presentation for the next meeting of the cross-sector task force. I think this is a great example of a short-term statewide initiative that could have a broad impact to address what we're seeing with more immediacy for overdose. And then second, I just wanted to follow up on Kat's point regarding naloxone access. Speaking for the program at the health district, we've seen it approximately like an increase year over year since 2018 of about 5,000 extra doses, and that's what the requests that are coming to us. That's not even necessarily being proactive to go out into the community and reach out to other areas. So we know that the demand has increased sort of year over year, and happy to provide more contextual information on that at a later date if appropriate. But I wanted to just echo Kat's point about demand. Thank you.
Thanks so much. Other questions?
Kat,
Comments?
Kat, this is Terry Kearns here in Vegas. I had a question. You talked about the cost of your supplies and the cost to ship, but one of your recommendations was about pickup for products for return for destruction. Does this factor in the cost for the destruction, or is that an additional cost?
That would be an additional cost. So there's different options for that. One of them could be having return bins that receive weekly pickup and are then destroyed that way. If they were to go down to Vegas, we already have the machine required to destroy them. It also would be possible to set up a contract with Republic. We actually already have one in Vegas with Republic Services for receiving biohazard pickup that's destroyed for things we can't destroy in our machine. So that would basically need to just cover the cost of the disposal bins plus staff to go do that. For shipping returns, which does exist for people that have medical waste returns, there's a lot of restrictions with that in place for protecting the postal workers, and that tends to be rather expensive per return. The cheapest I've found for an appropriate sized return would be like $42. And that would then also increase our shipping costs to get the items out to them as well, because we'd have to change the packaging that we're sending it out in. So that would increase it to probably bare minimum per person to send harm reduction supplies and not just naloxone to probably over $50.
All right, thanks so much. Deb, do you have another question?
I did, and I'm so sorry. I forgot. I'm sorry. Thank you.
Go ahead. Oh, you forgot your question. Okay.
Oh, I do. I'm sorry. I do remember it now. It was something about the
Okay, go
car.
ahead.
Didn't the government just pass something to make Narcan available to everybody in pharmacies? I mean, will that help with our state?
I'm not 100% up to date on the progress on that. I know that there has been things in the works. I wasn't aware if it had finally passed or not. And I'm also not entirely sure on if it would be free. But I know that Lisa has her hand up and she probably has the answer to that question.
Thank you.
Go ahead, Lisa.
Lisa Lee for the record. Yes, last week while I was at SAMHSA, they did authorize approval for over-the-counter naloxone. I'm not sure what that rollout looks like, but I think that's a huge win. So we got rid of the X waiver for Bupe, and now we have over-the-counter naloxone availability. I don't know about how that affects free naloxone programs. I don't know how that correlates with policies that in Nevada indicate that we need a standing order. I'm not sure of a lot of things on how the rollout will look, but they did approve that.
General Ford, Jessica Johnson has more info she'd like to add to Lisa's comments.
Okay, great, and then we'll go to Eric.
Thank you. Jessica Johnson for the record. To add on to what Ms. Lee said, so the FDA did approve for, my understanding is for Emergent Biosolutions Narcan, not all naloxone availability over the counter, so kind of one particular company. And in that ruling, from my reading of it, they also stated that other companies would need to seek FDA approval to then become over the counter. And it's not clear that at this time that will impact cost or how that will impact cost. So I imagine that most community-based naloxone distribution programs will need to continue in order to help reduce overdose risk. Thank you.
All right, thanks so much. Eric?
Yes, thank you. I would just add to Jessica's comment that I do think the community-based naloxone avenues that we currently have are still going to be needed. I listened to an in-depth analysis of the approval of naloxone over the counter, and it sounds like the pricing for this initial approval will be somewhere in the neighborhood of about $50 per dose, which is, I think, prohibitive for a lot of people and disincentivizing. So until that price comes down, I think the community-based naloxone distribution is still going to be needed.
Very well, thanks so much. All right, we need to go ahead and move on because we do have a strict time frame for the alternative pain treatment presentation. And so let's go ahead and move on to the next. Thank you so much, Kat. Let's go ahead and move on to the next presentation by Christine on post-overdose response staff. Go ahead, Christine.
Good morning, thank you. Christine Payson for the record, Drug Intelligence Officer with Nevada HIDA, representing Nevada Sheriffs and Chiefs Association. Next slide. I have no disclosures to date. Next slide. So I've got a quote here that I've taken from the Boston Medical Center that was published in the Journal of American Medical Association JAMA Psychiatry. And it's going to explain a little bit about the post-overdose outreach that I am recommending we use some of the opioid settlement funds for. So post-overdose outreach programs emerged in Massachusetts in 2013 as an approach to engaging recent overdose survivors, using contact information from emergency responses to connect the survivors to their social networks. And in the days after a person survives an overdose, an outreach team will attempt to contact them by phone or by visiting the home to proactively offer overdose prevention guidance, referral and navigation to treatment, and other community services. And these teams also offer support to families. Between 2013 and 2019, among 93 Massachusetts municipalities that had at least 30 overdose emergency calls in 2015, those municipalities that had implemented post-overdose outreach programs had a 6% lower annual opioid fatality rate than the municipalities that had not implemented any programs. Implementations of these programs was similarly associated with a 7% lower annual opioid-related emergency encounter rate than municipalities that had not. So they're seeing some success, and we're hoping to bring that to our area. Next slide. So the issue that we're addressing is we want to prevent fatal overdose, right? And again, quoting from that article, surviving an overdose is one of the strongest risk factors for fatal overdose. So reaching out and engaging overdose survivors in overdose prevention, like naloxone rescue kits and substance use care and medications for opioid use disorder, is a critical opportunity to prevent future overdose. Next slide. So this is something that would be equally available to all and would therefore benefit all of our special populations: veterans, elderly, persons incarcerated, pregnant women, LGBTQ, people who inject drugs. Every single one of our populations would benefit because it would be equally available to all. Next slide. So what's working well? Nevada HIDA has already been working with Southern Nevada Health District to develop some protocols for what this post-overdose outreach would look like. We know that the health district are already the experts in evidence-based practices and harm reduction strategies. So this would just expand those efforts and reach more people in need. We through these discussions, we've got a basic framework, but like any good program, we need proper funding to bring it to fruition. Next slide. So some of the gaps that we feel like this program would address is it brings an opportunity to provide linkage to care and harm reduction strategies that are currently lacking. It's a chance to connect with the family members and or fellow drug users who may be present and provide them with the same information and assistance. And the officers that are responding on these scenes, whether they're fatal or not, have expressed a need for a way to provide a warm handoff for the overdose victims and their families to these types of resources. Next slide. So the recommendation, like I said, was to set aside some of those opioid settlement funds to be used to fund a post-overdose outreach coordinator and other associated costs for starting and maintaining a program. Next slide. So there's the references, the top one being the article that I quoted. There's some information on current public safety-led post-overdose outreach programs and some case studies on how those are working for your reference if you'd like to read up on a little bit more. Next slide. And that is my contact information, and I will do my best to answer any questions.
All right, fantastic. Thank you so much for the presentation. Christine, are there any questions of Christine about the presentation? Debbie, your hand's up. Go ahead.
Yes, thank you so much. And I agree with you. This is probably the most important thing we can touch on. I know here personally, I've seen so many kids go into the hospital and leave without any support, anything, and overdose the next day. I also know in Mississippi, they have a program implemented where someone is admitted to a hospital with an overdose. They do not let them leave without a mental health specialist coming in, a support, a drug counselor. This is very important and we need this 100%.
Thanks, David. Any other questions, comments?
We have a question here in Vegas.
Okay, go ahead.
Hi, Attorney General. Dr. Dixon, for the record, this is not a question, this is a comment, I guess. I have been working in medication-assisted treatment since 2008 here in Las Vegas. I have never once had a new patient evaluation that was sent by a hospital, referred by a hospital after an overdose, or either in the emergency room or from this wards. So, you know, we are not doing this at all. I don't know where they're being sent. They do get sent sometimes to detox facilities, but a lot of the detox facilities are not particularly oriented towards medication-assisted treatment. So they tend to send them out into the street, home with no medications. So we have a long ways to go on this. I was up at Carson City yesterday, and I did end up talking to Mr. Patrick Kelly, who's the new CEO for the Nevada Hospital Association and their lobbyists, and he was up there lobbying. And I said, we have got to work with the hospitals. You've got to get the hospitals more onto the bridge program that we're trying to get. We've still only been able to get 2 or 3 hospitals even interested in the bridge program, let alone doing anything. So I think we've got a long ways to go. He suggested, though, that really the folks maybe to work with would be the discharge planners, because they're already hired and working for the hospitals. So I think maybe you made a tiny little inroad yesterday.
Thank you, Doctor. Lisa.
Christine, go ahead. Sorry, go ahead.
I'm sorry. No, go ahead. I'm sorry, go ahead.
Yeah, this is Terry Kearns, Christine. So for this coordinator position you're looking at, is this just for Southern Nevada, or are you looking at one for all HIDA areas or for the whole state?
Well, we'd start here in Southern Nevada because we've already, like I said, been in communication with Southern Nevada Health District on what to do. We're already exchanging data with them, and if we can show success with this, then of course we'd like to expand it at least to the other HIDA area, if not the entire state.
All right, thanks. Go ahead, Lisa.
Thank you, Lisa Lee, for the record. Great presentation. I'm such a big fan of post-overdose interventions. I'm wondering if there's an opportunity to work with the peer teams in the emergency departments at UMC. And I believe and that's through Track B, and then Foundation for Recovery. I believe they still have peers in Dignity Health neighborhood hospitals down there. So there are some post-overdose peer outreach that is happening within emergency departments. And I think that they could probably be really beneficial to what you're proposing here.
Thanks, Lisa. Any other questions or comments on this presentation? Okay. Hearing and seeing none, we are a little ahead of schedule, but I did see Dr. Narisi on the line. Doctor, are you available to go ahead and begin now?
Okay, I was unmuting myself. Sorry. Yes, I am.
Okay, very well. Then let's go ahead and get started. Thank you.
Of course. Perfect. So thanks for inviting me. This is one of my passion to help and fight the opioid crisis and substance abuse. And thanks for the time. So this presentation is about the novel idea of the pain urgent care and try to address the gap in healthcare system and how it does help to decrease the risk of substance abuse and opioid abuse. So we founded United Pain Urgent Care 2 years ago as a pilot one because of the gap in the healthcare system, that there is no access right away when the painful injuries happen. Typically, the hospitals and the normal urgent cares are just not trained for that type of injuries. They're like emergency rooms are good for basically life-threatening conditions, heart attack, strokes. But when it comes into, say, migraine attack, migraine headache, or just come from the sciatic, back, leg pain, things they may just do some imaging, but then they typically give some pain medication to the patient and they try to open a room for more life-threatening condition and go and see your provider. And that may take a few weeks even to get to someone. So majority of the time, the patient, they stay on the opioid and narcotics. By the time to get to any specialist, it's hard to get them off. And through some of the slides, I go through that why it's important. But let's focus on the part of the substance abuse and what we know. Currently, we are dealing with the crisis itself. It's a crisis, but In crisis management, one part is important for us is the risk management, because we want to prevent and mitigate before even happening. So when you look at the equation of the risk equation, that's mathematically, if you want to understand how you can address things that we know that is one of the hazard, we know that the risk equals to hazard times the quotient of vulnerability divided by capacity. So in terms of the substance abuse and opioid abuse, the hazard can be some painful injuries. At the end, you cannot do anything. The surgeries happen. You need just to get medication. You need treatment to address the pain or the mental diseases. They do exist. So these are things that you can't change. But what you can change is the quotient of vulnerability divided by capacity. That's where we come to play. And in terms of vulnerability, we have multiple things that we do see. It can be from the peer pressure to schools. It can be the drugs on the street, that like fentanyl can be the case, and meet disinformation that we have seen with COVID. That was big parts. These are the things that increase the risk. But the capacity is about the infrastructure. So there are two terms that we work on. One, resilience, how we can increase the resilience, and how we can increase the basically to improve the capacity building. So resilience in the part that not only to resist these issues, but also to be able to come back right away, to recover fast when it handle the risk associated with what we do. So when if you go to next slide for me, so that I can discuss about what is important to know. Yes. So one of the parts that we talked about, the emergency rooms, things that they don't have the room and the capacity to treat. So what we are going to do is what I call that ERA. ERA is the key component to improve the capacity building and resilience. ERA stands for education, regulation, and access to alternative options. So we've done a good job also to educate people. Still, we need to do more. I think we've done better job for diabetes versus the opioid. But regulation, we have the laws to regulate the opioid, but that's not the case. We need also to give them an access to alternative option that does not exist in the current system. Just giving a simple example. If the patient, if you're trying just to say, oh, I'm going to change the unhealthy and fatty food away, want to make sure that everyone eat healthy, so I'm going to put a regulation, just take the unhealthy food away. But you cannot let the people stay hungry. You have to give them the healthy option. You have to give them the access to that. So in current system, when we regulate some of the medication for opioid, hey, prescribe this one that way, but also we need to provide them the access to something else instead, and that does not exist. Why is important just to give them some non-opioid options? Let's look at, if you look at the slide, the British Medical Journal and also JAMA Intramedicine and said that each prescription of narcotics associated 44% increase in the rate of misuse and abuse. These are the people who are naive, never had any opioid, but unfortunately they injured themselves or they had a surgery, and you give them the opioid instead of other medication or other alternative option. So that's 44% increase in that. And plus, every week that we increase the prescription, like we give them another prescription of opioid, we increase that by 20%. So that's where the alternative option or access to alternative option comes to play. For example, in the pilot run, so someone comes in, say, with back pain. So instead of just doing the opioid narcotic things, we treat them with some of like trigger point injections, some of the injections that can be done easily, can be epidural, things that typically we know they're effective, but we always do them in chronic phase because we never thought of the issue of the opioid in first place when we looked at these studies before 2016. And that's where we come to play. We need to bring the treatments from where it was done before chronic in acute setting and prevent people, just to give them an option basically for treatment of their pain or painful injuries. And that's a key, but the challenges we do face are also many. If you can go to next slide for us. One is you have high-risk people. So some of the people, the athletes, they injure themselves, the youth that they get in sports. So they're currently, if they just injure themselves, if they break, you put a cast, you do surgery, you give them some narcotic opiates and go there. Something that I'd like just to mention that by the time these patients that get to emergency rooms or the urgent cares, they have tried the over-the-counter medication, pain medication. The pain is so significant for them. So it's not current system or physical therapy is not going to do anything for them because they're in so much pain they can't even do anything. Or the medication over-the-counter, Aleve, naproxen, they have tried, it doesn't address. That's why we'll come to play. So give them the alternative option beside the opioid. And even say addicts want that they want to stay from opioid because they know that if you give them the opioid, that's a reward pathway. It makes the situation worse again, that kind of scenarios. Next slide for me, please.
Thanks, Doctor. We've reached the minute mark. Let me jump in and see if I can have you to move over to your recommendations and share them with us, so we can open up some questions from there. Thank you.
And yeah, recommendation, just want to say that what we do, we need to basically make sure that we have access not only in parts in the arena, but also we can have it across the state, the same model that we provide for urgent care in like a pain situation when painful injury happens. And also we make sure that the insurance companies, the payers, they act be like exactly emergency room. So they waive those prior authorizations to perform these procedures in early setting when the injury happens. And we have shown in studies that's cost effective. They save 546%. So that also can help the Medicaid programs to save money by offering this type of procedure to the patients in early settings. That's all I have.
Doctor, thank you so much for this presentation.
Of course.
Very, very interesting. Let's open it up to questions. I see Debbie's hand up. Go ahead, Debbie.
Yes, thank you for that presentation. I'm glad you brought up prevention, because that's a big part of it. And I know we've talked about this many times, but I don't know how we can do this, but I think it would behoove our whole state if we had certified drug and mental health counselors certified in our mid schools to high schools. These kids have to have somebody to go to. And I think this is something that will help our whole state with these young kids, knowing they can go there and talk to somebody.
Absolutely. Even the injuries, what we have seen, the injuries during sports, they don't, when they go to normal treatments, they just cast, brace, whatever, but there's no options and there's no like treatments set in a way to give them the relief without using the opioids. And that's the key component. If you try to not expose them to that, you may save so many people by not being basically addicted to the opioids, by preventing and make sure that they don't get that opioids in first place.
Yes.
I agree.
We have a question in Vegas.
All right, go ahead.
Thank you, Attorney General Ford. Jessica Johnson for the record. Thank you so much for this presentation on alternative pain treatment. I would love to hear more in these recommendations. What do you think the barriers are for large-scale implementation of alternatives for pain treatment, specifically cost, insurance access, et cetera? Thinking about folks who may not be able to afford something otherwise that's not covered under an insurance. I'm really curious about your thoughts. Thank you.
Of course, yes, that was a great question. So in one of the slides, we didn't have a chance to go over. With Prominence Healthcare, we did a study. So we did a cost analysis study. If the patient goes to emergency rooms versus come to us, in emergency rooms, they don't even get the treatments that when they get in our urgent care because they're not offered there. But even the treatment's better, but the cost effectiveness was 546% less than emergency room. So imagine that how much even the Medicaid or CMS program, Medicare can save, or any payers, by sending these patients more into that designated pain urgent care to get the option, better option, plus with the less cost. So with cost-wise, we are confident that based on the study that we did with Prominence, is huge saving costs in these patients. The only big part is the good news is with Medicaid and the Medicare programs, it's all about the medical necessity. We don't need to obtain a prior authorization. But when it comes to the private payers, a lot of the payers, they require you to do all the prior authorization. And that may take up to 7 business days even to get any. In acute setting, we need to proceed. It's like emergency rooms. When it happens, we need to make a decision and proceed with the treatment, not wait for the payer just to make a decision. Okay, now you can proceed. And that causes the problem, because then you introduce narcotics because these patients are suffering and you cannot do anything else instead. So that's the big barrier for it. And I think the cost-wise, if just way less than anything compared to emergency rooms, so it should be easy to kind of go in bigger scales.
Great question. Thank you so much.
Permission to follow up, Attorney General?
Yeah, absolutely. Go ahead.
Great, thank you. Jessica Johnson for the record. So one more follow-up question, and perhaps this is included in the resources provided. I'd love to read the study that you just mentioned. Is there any studies that have looked at like patient quality of life or quality of experience for patients with alternatives that your group has performed or other research has performed that informs your practice?
Thank you so much. Yeah, the treatments, so you were dealing with acute and chronic. The treatments that we've done for chronic. So we have all studies about improving the quality of pain when the patients, they suffer from pain, and we offer these treatments. But the idea is so novel for acute. In acute setting, we never studied these things before. We're shifting the treatments that have been effective before in chronic setting to acute setting. So we don't have currently the improving the quality of life to look at the acute pain, but we're confident that's basically pain is pain. So we're moving it from chronic to acute setting. We know that in chronic, those studies that we've looked at, they're all showing improving the quality of life, and we can provide those studies to you.
Thank you. Other questions?
Of course.
None. Dr. Narisi, thank you so much for your presentation. We appreciate you. We will move on to the next presentation. Safe smoking. Shiloh, mic's yours. Awesome. Shiloh, you there? Okay. All right. We will. I saw him earlier. I don't see him. Okay. Charlotte, if you're there, we'll come back to you. Let's go ahead and move on then. Jamie Ross, who can present of community health workers and harm reduction. Jamie and Wendy, go ahead. Do we have Jamie and Wendy? There's Wendy.
Good morning. Can you hear us?
Good morning.
Thank you. Good morning. I'm Jamie Ross. I am with the Nevada Statewide Coalition Partnership as well as the PACT Coalition. And
Wendy Madsen. I am with Healthy Communities Coalition serving Lyon and Story County. Good morning.
Good morning. Please proceed.
Only disclosures, HCC houses the Community Health Worker Association. And we'll talk about.
Could you speak up just a little bit? We can barely hear you.
Sure, thanks. Sorry, we are in a loud location, so apologies if you get a little bit of background noise. Next slide, please.
Okay, community health workers. Community health workers are frontline public health workers who are trusted members of and or have an unusually close understanding of the community they serve. CHWs are a vital connection between individuals and healthcare systems. By closing the gap of not only professional shortages, but also cultural understanding, a CHW can provide access to care and understanding of complex health issues. A CHW's job description can include a wide variety of tasks, including advocating for individuals, families, and communities, serving as home health aides, becoming health educators, organizing street outreach, coordinating community events, navigating patients through a complicated system, and education and outreach of prevention and harm reduction. The history of the community health worker. Community health workers, oops, I am having technical. Okay, in recent years, the Nevada Division of Public and Behavioral Health has taken the initiative to promote the CHW profession in the state of Nevada. DPBH launched a CHW pilot program in 2013, training 14 CHWs from around the state and placing them in 6 different community coalitions. CHWs performed a variety of tasks through their placement in the coalitions, including collecting data for Latino health needs assessment, enrolling individuals in Affordable Care Act coverage, and connecting individuals to healthcare providers and other community resources. Since the pilot program ended, some of the coalitions elected to hire CHWs to continue serving the communities. And currently, I believe all coalitions across the state house CHWs. Additionally, CHWs are similar positions with varying titles, are found at a variety of agencies, organizations, healthcare providers throughout the state. The state has collaborated with the Nevada System of Higher Education to offer CHW trainings. Currently, TMCC, CSN, High Sierra AHEC, and the Nevada Community Health Worker Association offer trainings. And High Sierra AHEC offers a pipeline training for high school seniors to be trained as community health workers, and with a certificate of completion upon graduation. The next is harm reduction efforts currently underway in Nevada. CHWs are expert at meeting people where they are at, bridging the gaps between primary prevention and harm reduction. They understand the importance of building relationships and thus trust with those in the community. Specific to harm reduction, our CHWs are trained in naloxone education and the delivery of naloxone, fentanyl test. These CHWs are placed in a multitude of environments that have the capacity to deliver this education. In a broader sense of harm reduction, CHWs are well versed in food insecurity needs, social connection to behavioral health and wellness. So we really look at harm reduction in that really broad sense.
So currently there are CHWs in every county in Nevada, and we've spoken a little bit about scalability. And what we know is—
Can't hear you, I'm sorry.
Can you hear me now?
Barely.
Okay, here, I'm gonna get real close.
There we go.
Okay, perfect. So what we know is that the CHWs that we have in existence are doing an amazing job, and they are often our frontline harm reduction specialists. They are the ones who are working directly with people who use drugs in food pantries, at schools, in our community settings. And that's really why the coalitions have been incubating this process since about 2014, was when community health workers were introduced in Nevada through projects that Wendy just spoke about. And so we can go to our next slide. And Wendy already spoke a lot about this, but some areas where our CHWs are already working as harm reductionists, they are in our food pantries. Our CHWs are routinely handing out Narcan. They're handing out fentanyl test strips. They're doing training of folks who may not be comfortable walking into a syringe exchange program. They are serving a different population than some more traditional harm reductionists are, and they are really broadly in our communities. So that's one of the reasons that we are pushing for community health workers to be more recognized as harm reductionists. Next slide. So here's some evidence. What we know is that if we can keep people out of ERs, if we can prevent overdose, this is significantly cheaper than keeping people in ERs and continuing to do all of that. And there is information about where that data lives at the end of our presentation. Next slide. And so I think you guys know what we're going to be asking, because it seems as if that's what everyone is asked, is funding to scale up existing programs. Historically, what Nevada is great at is finding money to do a pilot project, and pilot projects are great. And then we're like, yes, this program works. And then, but we don't have money to scale it up. And so we are hoping to request prioritization of funding for community health workers as harm reductionists. And that is our ask. And I think we're just at time.
Very well. Thank you. Listen, I think I've been informed that we did make a recommendation to request more money and support for community health workers in our last annual report. So that's worthy of noting. With that, let me turn to questions. I see Shayla's hand up, and then we'll go to Debbie. Shayla?
Thank you, Shayla Holmes, for the record. I just want to say thank you to Wendy and Jamie, and make the comment that I see our community health workers, particularly in our rural communities, as the method to make some of these other presentations we've seen happen, such as the postvention coordinator. I think that role is a fabulous idea, but how we make that and really implement that in our rural areas, I think it's going to take community health workers to get connected to individuals post overdose. I also think in regards to the previous presentation, as far as education on alternative pain management, it really takes the rapport that our community health workers build with their clients to really educate folks on those alternatives and help them make those most informed decisions. So I see community health workers in a variety of different ways in these other presentations of which we've heard today, and really the way that we make those happen for our entire state as opposed to not just our more populated urban areas.
Thanks so much. Thanks, Shayla. All right, Debbie, and then we'll go to Vegas.
Okay, thank you so much. Thank you for everything you're doing. I just have a question. You talked about primary prevention and school programs. Is this something you're working on? Or what have been done? What have y'all done in the schools as far as focusing on the prevention and to help our children learn to say no? I mean, are y'all working on something now?
Yeah, currently we have community health workers as part of the safe school professional teams in schools. So they serve as that connections resource in addition to prevention, education, and strategies. And again, that because they are placed in the schools and they build those relationships with the youth, it's far more effective delivering that education and those supports. So yes, it is currently in place, and we'd of course love to broaden that into every school. That would be amazing.
And one more question, I'm sorry about this, but is this being done in Southern Nevada? Because the schools that all my friends' kids go to, there's nothing. They're not seeing anything on drug awareness. I mean, I've heard from numerous people. So is it just a set number of schools or every school? Because I'm not seeing anything in the schools around my area.
Thank you, Debbie. This is Jamie. And yes, there are pilots, but they're very, very small. There's about 4 schools in Las Vegas that are working on this.
Can you speak up a little bit, Wendy?
Good morning again. This is Jamie. Thank you, Debbie.
Jamie,
and
I'm sorry.
yes, that's okay. There is pilots, but they're very, very small, and with about 350 schools in Clark County School District alone, scalability becomes a really big challenge in Las Vegas.
Yeah, no, I understand that. And I actually want to email you, but I'll ask you something. Thank you so much, Jamie.
All right, let's go down to Vegas.
Thank you, Attorney General Ford. Jessica Johnson for the record. I have a quick request from Debbie's last question and then a question for Jamie and Wendy. I was hoping, Debbie, to follow up on your question to have a presentation at one of the upcoming surge prevention subcommittees regarding the primary prevention programming, hopefully statewide, and if Jamie's available to do that from the statewide coalition partnership and or other coalition partners, to hear more about some of the gaps there. To move back to the harm reduction piece today, I'm wondering if your group can say more about why community health workers instead of like a peer recovery support specialist or other type of group. How do you see that as sort of the component for a recommendation or the method in terms of the CHWs?
Thank you so much, Jessica, and I guess through you, Attorney General Ford, Jessica, thank you so much.
Oh, you can go straight, that's fine.
Fabulous. I'm terrible at open meeting law requirements, so thank you. Yes, so I think the coalitions would be happy to put together a presentation on what's happening with primary prevention in schools through coalition. Question. As far as your second question.
Oh, Jamie, you got to speak up. Sorry.
That's okay. Can you hear me now?
Yes.
Okay, wonderful. So I think there is quite a bit of overlap in what peer recovery support specialists do as well as what CHWs do. One of the things that we do know is a difference is peers have lived experience with substance use. And while that can be incredibly valuable, and we definitely want to support that, and we know that there are peers working in the harm reduction field, we also know that when done, it can be a trigger for relapse for our peers, and we definitely want to protect them. So this is an and, not an or. So we think both peers and CHWs are a great method for this, and not one to the exclusion of the others. I hope you could hear me okay.
Yes, I can. Thank you.
Jamie and Wendy, this is Terry Kearns. I had a question for you as well. So under the community health worker model, I know that it falls and reimbursement falls under the chronic health conditions, but can you speak to what services are covered under insurance, Medicaid, Medicare, those types of things? And is there an opportunity to look at trying to expand coverage under those different models?
This is Wendy. So we were successful the last legislative session to get Medicaid reimbursement for community health worker services under the medical model with supervision under a doctor, RN, or APRN. This session, we are bringing that back around to broaden that supervision model to behavioral health and beyond. So currently, there is Medicaid reimbursement for more of the chronic disease piece. There's in the schools, community health workers do have the ability to, for schools that are ready to bill Medicaid under provider type 60 for a multitude of services. So, you know, as community health workers have become so recognized and popular, this will continue to expand. As far as private insurance, I honestly do not know the answer to that.
Okay. Thank you.
Jamie, we can't hear you.
I swear I normally have such a loud voice. Yes, this is Jamie, and we will follow up with private insurance and get back to you on that. Thank you so much, Terry.
Okay. I heard you say you'll follow up and get back to us on that. Okay, thank you. Other questions? Okay, Jamie and Wendy, thank you so much for this presentation. Thank you for agreeing to follow up with some of the answers to the questions that were raised there. Here's what I'm going to do. We have, it's at 9:50 right, I'm sorry, 10:50 right now. We have one more presentation and another couple of agenda items. Let's take a 10-minute break and come back at 11 o'clock, everybody. We'll see you in 10 minutes, okay?
I'm going to close it.
Okay, welcome back, everyone. We are at the 11 o'clock hour. We have one more presentation and a couple of other agenda items. And so let's go back to Shiloh, who's going to present on safe smoking. So Shiloh, go ahead.
Hey, can everyone hear me?
We can, thank you.
Perfect. I'm having some internet trouble, so if I go out, I apologize. I'm going to be presenting on smoking service. My name is Shiloh Jama, and I work at Safer Alternatives through networking and education, and I help develop and create the first heroin pipe. One of the things that working with smokers and developing smoking services I thought was super important is, for example, when we created or put out the meth pipe, 30% of our meth injectors switched to smoking because they didn't have access to those pipes. They also reported using less. And so I think smoking is a really good harm reduction intervention when it comes to people who have, like, for example, who have abscess and wound care issues. Switching to smoking can help them heal. It also, for folks who want to reduce their use, can for folks who want to reduce their use, the switching to smoking, they get less of the drug. Also, because of that, it makes it a lower rate of overdose for folks who are smoking drugs. And because I'm afraid to lose the internet, I'm going to just go really quickly to questions, so I don't get knocked out halfway through this.
Okay, Shiloh, thanks. Questions, comments? Anyone have anything to offer to add on what Shiloh said thus far?
We have a question here in Vegas.
Yes.
Okay, go ahead.
Hi, thank you, Attorney General Ford. Jessica Johnson for the record. Shiloh, thank you for being here today and for the work that you do through SANE. I was wondering if you could speak a little bit about the expansion of syringe services programs, like traditional syringe services programs, when they include smoking products, and sort of how, is there any evidence about increasing the network of services, or who is coming in for types of services?
Yeah, I'm really glad you asked that. So a lot of times there's the initial group of people who are switching from injection to smoking. Then there's the added group of people who are smoking that then we can get Hep C and HIV tests. A lot of times that community has been really underserved. And so, you know, for example, when we added cocaine smoking kits, there was a whole bunch of folks who didn't even like understand, and we needed to educate them around their own risk factors. And they were able to get Hep C tests, HIV tests, you know, and then also it's an added thing to syringe injection drug users. A lot of times we are connected to a Suboxone clinic, right? So with opiate smokers, they're not really connected to any programs. And so thus being connected to our program that has made it so they can connect to a Suboxone has made it access to treatment, right? And education, right? And then it's also, you know, I think, so those are the really positive systems to connecting to smokers.
Thank you.
Lisa.
And I really apologize about the internet here. It keeps going in and out. And so I just didn't want to like lose anything.
That's fine. No. Go ahead, Lisa.
Thank you, Lisa Lee, for the record. Shiloh, thank you for your presentation. Here, I don't know what it's like in Southern Nevada, but I can tell you up here, lots of folks have transitioned from injecting to smoking in the last couple of years. And so my question is about funding sources for offering safe smoking supplies. If you've identified any great funding mechanisms. And then the other thing is legal barriers to implementations for SSPs to incorporate safe smoking.
So I work in California. I guess that should be in my disclosure section. So in California, we have the a clearinghouse, and so the state pays so we could get syringes and smoking equipment. So they've already worked out some of the legal issues, which I'm happy to connect you know, folks from the state of California. And there's multiple states who now provide smoking services. So it would be really around your local state laws and regulations, simultaneously with funding mechanisms. Honestly, the health department, health and HIV funding is the #1 funding mechanisms for harm reduction organizations. And so that would be the #1 things. I can tell you, like, if you think about the cost of having someone like providing syringes for someone for a week and providing someone a pipe, the cost is definitely lower to provide someone a pipe, right? So you are saving money. And the reality is you're not having the same risk factors. So if you are now smoking, the likelihood of you getting HIV, hepatitis C, soft tissue infections, overdose, right? And now with fentanyl hitting the market, people can go to smoking and still feel like they can get their high, but also lose a lot of the risk factors of a lot of things. So it's a net benefit for everyone in the community.
Thank you.
Thanks, Lisa. Debbie.
Yes, thank you so much. My question for you is, are you saying that if someone is smoking, let's say heroin, and there's fentanyl mixed in with it, that it decreases their risk for death?
Yes, it would reduce the risk of death. Now, saying that, if it was incredibly potent fentanyl, and it was a high percentage, let's say you had an extreme percentage, like 30% of what you were about to smoke was fentanyl, it would again reduce the things, but that would overwhelm the, now, essentially what historically was pre-fentanyl was that by the time if you were injecting, by the time you felt a rush, you could be already going towards an overdose. Where in smoking, because there were smaller hits and less concentrated, you were more likely to fall asleep than you were to overdose, right? So there was the difference. Now, fentanyl, of course, has changed the entire system, and so you are less likely to overdose by smoking, but that does not prevent overdose because of fentanyl.
Yeah, unfortunately, I've seen a lot of moms post that their kids were smoking and their children died of fentanyl. So when you're providing the safe user pipes and everything, are you also talking about are you encouraging them to still test and use fentanyl test strips and the likes, stuff like that?
So our education around overdose doesn't change regardless of what drug or means of drugs you use. So if you're a stimulant user, for example, we still will provide you with Narcan. We will still educate you with Narcan because the best thing is to use together and use and not use alone. And so if everyone has Narcan and everyone is educated in overdose prevention, then we have a better shot of preventing overdoses. So again, I encourage people, anyone who's working with stimulant users, to still have overdose prevention strategies around opiates, because we've seen in some cases that fentanyl will enter the methamphetamine or cocaine market, therefore making it likelihood of overdoses because they have very low tolerances. So I think it's always important to do overdose prevention in every aspect.
Okay, thank you.
So a question in Las Vegas.
Yeah, thank you, Attorney General Ford. Jessica Johnson for the record. Shiloh, I'm really learning a lot and I'm appreciating your Q&A approach here. I was wondering if you could educate our committee a little bit about the different types of pipes that SANE distributes, and specifically what kind of substances they're focusing on or targeting.
So we have, sorry.
Go ahead.
So we have 3 types of pipes, right? And I think it's important to know that we have like 9 different kinds of syringes, right? So we have 3 types of pipes, one designed for fentanyl or opiates, one designed for methamphetamine, and one designed for cocaine, right? And so it's, and so there's 3 different ones. And unfortunately, I don't have a lot of time. The opiate pipe looks like a hammer. It's ways that you could do a dab hit, or you could do a slow roast. The methamphetamine pipe has a big bulb at the end, and so you can kind of do a rotating heat source to kind of get it. And then the cocaine pipe is a long cylinder. And we provide all of them. We also provide fentanyl test kits, we provide syringes, we provide wound care. And, for example, on the heroin pipe, we have an instructions on how to use, but on the back of it, we have our Suboxone clinic information. And we have a lot of folks who are coming to us for, smokers who are coming to us for Suboxone and for treatment. And I think it's really important that if you're not accessing the smokers populations, these are ways that you can have negative health outcomes, and they become more isolated. I think harm reduction, like from a core value, needs to do better and reaching out to as many populations as possible. If you think about the concept of preventing HIV, for example, right? If you're not trying to reach to every single person you can around, whether it be through sex or drugs, smoking, snorting, or injecting, when it talks to drugs, you're limiting your reach. And I think it's important to try to get this best reach as possible, because we know this is a numbers game. The more harm reduction supplies we get out there, the less likely we're going to get infections.
Thank you.
Great conversation. Any further questions?
I do have one last. Oh, sorry. I have one last closing statement that I haven't heard here, and you know, in my work of 27 years, I think the best, and I know it's hard to legislate this, but the one of some of the best work we've ever been able to do is by building people's self-worth and building love back into the community. There's a lot of stigma for folks who use drugs, and the more we can institute building like the fact that these are people's children, these are people's brothers and sisters, these are valuable members of our community that we want to support and help and build that self-worth, the better health outcomes we can have. And so it's just one thing that I'd like to make sure everyone on the committee hears. And again, I know love is hard to legislate, especially in this political climate, but I really hope we can find a way forward to make lives better for people.
Appreciate that, Shiloh. Let me ask you a question. Is there a particular recommendation that you want to provide to the committee?
I would recommend that you provide a smoking program in every syringe exchange that you have right now in order to help reduce overdoses, wound cares, HIV infections, hepatitis C infections, and especially knowing that the syringe exchange are the best place to link people to treatment. I think those it would be there would be the best case scenario for those to provide PIPE programs. And I'm happy to do any trainings or anything support for any individual programs that would like technical assistance. I think this is really important. We've been working on this for over 30 years.
Thank you, Shiloh. I really appreciate your presentation. Okay, any further questions or comments before we move on to the next agenda item? Okay. Very well, thank you. Thanks again, everybody, for these extraordinary presentations. It's been very enlightening and informative. So let's move on to agenda item number 5, which is an opportunity for us to discuss and elevate specific recommendations to workshop. And in that regard, I'm going to refer you to the handout for a list of the SURG member recommendations and the presenter recommendations that are related to harm reduction. If you recall, we convened this particular meeting on harm reduction because many had requested that we even contemplate creating a new subcommittee for harm reduction, which we just don't have the capacity for. And so this meeting was to enable us to have a conversation, clearly a broad-ranging conversation around harm reduction. But now we need to contemplate what specific recommendations we'd like to elevate, potentially send back to the relevant committee for fleshing out or retaining here at the SURG level and putting it into the basket of recommendations we may consider going over to the advisory committee for Resilient Nevada. So with that, I suspect that those who made the recommendations, who did the presentations, are going to have a great affinity for the recommendations you've raised. And those may come up to the top of what you would suggest. But I'd like to have folks think outside of your own presentations here. And let's see if there are a few recommendations that rise to the top that we know we can kind of send back to committees, potentially a workshop. And I'll open it up for discussion. I have a different approach we can take if we can't come to a consensus on a few things right now, but let's start with the conversation. Debbie, go ahead.
Yeah, I was just thinking maybe we could do one of those doodle forms where we all fill out what we feel like we've done in the past, what we feel is most important. I don't know, just a suggestion.
You read my mind. That was actually going to be the main suggestion that I made, but I did want to give an opportunity for preliminary discussion on that. But yes, the weighting process that we've done in the past to help determine which recommendations we're going to be presented to the larger committee is something we can certainly do. There are 28 recommendations that are between members and presenters, and what we can do is simply have everyone sent individually this list. We're on a weighted format that we've done before, and between now and the next meeting, we can tally that and go from there. Am I thinking about that okay?
Shiloh's recommendation.
And it would be 29 because we'd add Shiloh's particular recommendation as well. So All right, I see a question up in Las Vegas. Go ahead, or down in Las Vegas.
Yeah, thank you, Attorney General Ford. Jessica Johnson for the record. I will support this when it comes to a vote for moving the recommendations to possible prioritization poll. I wanted to make two quick comments if appropriate. I would like to see the Bad Batch app recommendation and the shipping recommendation also be considered for the next cross-sector task force meeting if that group intends to reconvene. From my understanding of the purpose of that committee, those seem like very things that could be implemented with a relatively short timeline and or are already being implemented and could be either scaled up or added to in a way that would really remediate some of the overdose issues that we're seeing.
Dawn Yohe is the staff member on that, and I'll have to defer to her on whether the committee is going to convene again and the appropriateness of your request there.
Thank you.
Good afternoon, Attorney General. This is Dawn Yohe. Do you mind if I respond to that?
Go ahead. Yeah, please go ahead.
So I do have staff. I've been taking notes, Jessica, of what you would like to see at the next joint task force. And then I do have staff that's going to be sending out a doodle. She's just out of the office this week. I think we are going to try to convene in June. I do have some committees, I guess you will, or pods of members from the original action plans. And so that will be going out within the next 2 weeks as well.
Okay. Okay, thank you. So I will leave the mic open for another couple of minutes, but I think your silence is acquiescence to this notion of a weighted process where we're going to have everyone get sent an individual email and we'll go through their process. But any further comments, questions, concerns, complaints on this for now before we move on? Yeah, Las Vegas.
Attorney General Ford, Jessica Johnson again, for the record. I am hopeful, and maybe this is further discussion with staff to the committee about identifying areas for overlap. Some of the recommendations do overlap with some of the committee recommendations. And so I don't know if there's time or appropriate to do that now, or if there's a way on the poll to suggest merging some of these recommendations as a way to help streamline for the committee. And then speaking on behalf of the prevention subcommittee, our group is happy to staff any of the recommendations that the full SURG wants to have workshopped and bring that back in the fall if there aren't other subcommittees where there's a clear appropriate location. If that's an okay thing to say. Thanks.
Yeah, absolutely. No, I appreciate that you volunteer. And frankly, I thought prevention is probably where this would have gone anyway. So that's great. I mean, there may be others who want to engage in the conversation. That's fine too. But to your point about potential overlap, I'm looking at one of my team members here to see is this something you can do on your own to overlap, or do you want any
If they have suggestions now, they can list by number. We think 9 plus 10 go together.
Okay. The request is if you have suggestions now where overlap is, go ahead and mention those. If you like, for example, 9 and 28 overlap. I'm making it up, but so Jessica, if you know of anything right now that you think overlaps, you can say it out loud, and let's go from there. And then we'll go over to Lisa for her question.
Yeah, thank you, Attorney General Ford, Jessica Johnson, for the record. I would need to probably comb back through the presentation and the recommendations to ensure that. So apologies that I don't have that ready at the moment.
No, that's fine. It's a great suggestion, and I don't know if anyone has that just yet. I'm going to ask out loud my staff member if we can do it. If individual members can communicate directly to staff what they believe are the overlapping items, and staff can amalgamate all of that into the proper format for weighting. Is that okay? I think it's Hina. Is that okay if we do it that way?
I'm sure, yes, that would be fine. Yeah, just ensure that no one speaks about this amongst each other, none of the committee members. But if they, the contact person with the recommendations are to staff in the office, that should be fine.
Okay. Okay, so why don't we go that approach unless someone has suggestions now. With that, let me go over to Lisa.
Thank you, Chair Ford. Lisa Lee for the record. I just wanted to thank our presenters and really thank the SEI team for arranging all of these presenters to speak to us today and offering information and recommendations. And I am also in favor of the process. You know, SEI does a great job sending out those polls. But I did just want to thank our team for bringing all of these folks today to us.
Yeah, SEI is absolutely fantastic. You guys are really, really great at this. And so thank you for that. I did what Lisa just said. Vegas, your hand is still up. Is there another question? I'm sorry.
No, we'll put it down, sorry.
Okay, that's okay. Okay, any further questions, comments, concerns, complaints on this particular agenda item? Otherwise, I think we have our marching orders. Going once? Going twice. Okay, let's move on to the next agenda item number 6, which is a review iteration of items for the next meeting. This is a discussion item only. Dr. Kearns, let me give you the mic as well as Ms. Rodriguez.
Sure. So for our next meeting, as you can see on the slide, these are some topics that we thought would be good for agenda items, but we are also open to any suggestions from the committee members. As you can see, kind of a status update of the current legislative session, and then a review of our proposed amended bylaws with the updated member appointments and terms. The update on the opioid litigation settlement funds and distribution, as Mark Kruger always provides for us. An update on the status of the ACRN and the cross-sector task force. And as well, then a update on the Fund for Resilient Nevada. And then each of our subcommittees, the prevention, response, and treatment and recovery, will provide report outs.
Looks pretty comprehensive. Yeah.
Okay, and the date, I was just going to say the date for the next committee meeting is, we're getting it just a second for everyone. We had already scheduled them out, so we'll just update on what the date is.
Okay.
That was July.
July 12th.
July 12th at
2 p.m.
July 12th at 2 p.m. So if you didn't have that on your calendar, please put that on your calendar.
Thank you so much. I'm looking right now. I think I am good, but Vice Chair Lee, if something comes up and I may not be able to make it, are you available on the 12th? July 12th?
Thank you, Chair Ford. Lisa Lee for the record. I'm not sure yet. I'm scheduled for major surgery. Well, it hasn't been scheduled yet, but probably soon I'll be scheduled for surgery around that time. So more to be determined as I find out that date. Okay,
all right. Thanks so much. Okay, Terry, anything else from you on this agenda item or anything from you, Ms. Rodriguez?
No, I would just add if someone else has a topic and it comes up after you leave the meeting when you have, you know, the brilliant push to your brain, please forward that to me because I know sometimes on the spot you'll be like, I wish I had brought that up. So please reach out to me if something does come up.
Thanks,
Jessica. Jessica Johnson has something. Hang on.
Yeah, go ahead, Jessica.
Thank you, Jessica Johnson for the record. Thank you, Dr. Kearns. With regard to the subcommittee report outs, what would be, I like to have a to-do list. So as we're in the subcommittee, ensuring that we're preparing the recommendations. So is the goal in the report outs to share recommendations that we've heard so far for just presenting to the broader surge and identifying maybe any additional areas for broader presentations? Is that the goal?
Yes, that's the goal. And then also if there's any specific presentations that you might have heard that you want to report out on those specific presentations as well.
Thank you.
All right. Thanks so much. We'll move on then to agenda item number 7. I'm sorry. Oh, Debbie, go ahead.
Yeah, sorry. Real quick question. Thank you, Dr. Carnes. Question for you. The Nevada legislator update, are they still in session, or how do we know what things got passed? I just want to know if they mandated the Narcan in the class in all schools.
They're just barely passed.
By the time the next meeting comes around, Debbie, the legislature will have finished. They're done on the first Monday in June. So the July meeting, you'll be able to get a full debrief on what happened in the legislative building.
Okay.
And AG Ford, I'd like to add something I forgot is SCI has compiled a list, which was in the documents, the supporting documents, of specific legislation that would align with some of our recommendations that would be of interest. So we provided that in the supporting documents for you to look at, and it has the status, I think it was up to a couple of weeks ago. So the plan is to continue to update that. It won't be like a real-time 24-hour, but like perhaps once a month that will be updated, and then we can provide that to the members just so you have an idea of what we as a surge are tracking and the current status as of just a couple weeks ago.
Thank you.
Thank you.
Lisa?
Thank you, Chair Ford. Lisa Lee for the record. If I could just respond to that, there's a quick, easy way to track bills. Excuse me. If you just Google Nellis, Nevada, you can open up that portal. You can do searches for, whatever kinds of words that may be contained in the legislation, and you can track them. You can open up an account and track those bills. You'll get a legislative update on the bills that you're tracking, including whenever it moves into any committee hearing or is heard anywhere. So that's a good way to track that, Debbie.
Thank you. I will. Thank you.
Okay, let's move on to public comment. Do we have anyone who wants to speak in public comment? 3 minutes is the limit per person. Christine.
Thank you, Chair. Christine Payson for the record. I just wanted to comment. Debbie had asked earlier about presentations in school, and I just couldn't find my hand raised feature fast enough, but Nevada HIDA is reaching out and giving some presentations in the school, mostly by request on drug trends and dangers for our youth. So if anybody wants any more information on that, they can contact me.
Thanks, Christine. Vegas.
Hi, Giuseppe Mandel with Tin High and Alternative Peer Group Las Vegas. Thank you guys all. It's very informative. I mean, I learned a lot today, and I do always appreciate you guys having us here, or myself here. Couple quick things. I mean, we have Recovery Advocacy Day coming up, April 27th at 9 a.m. That's a live stream. You can register that on to attend that. I'm sure a lot of you are already familiar with it. I figured I'd just go out. And our Aim for Recovery is coming up April 29th. So I'm sure all of you guys are familiar with that too. Shooting and golfing kind of blended together for a great cause, all goes towards adolescents. Creates better awareness. And again, I appreciate all the information. I did learn a lot, especially about the smoking sites. It helped open my eyes for it a little bit. So I appreciate that. And I appreciate you guys all being here.
Thanks, Giuseppe. Great to have you here. Unfortunately, I'm going to be at the the National Judicial College in April during the time frame. Otherwise, I'd try to tune in. But thanks for all the work you're doing as well. Keep it up, man.
Thank you, sir.
All right. You got it. Track B, and then we'll go back to Christine.
Thank you. This is Rick Wright with Track B and Impact Exchange. And I'd just like to thank everyone for today's presentations. They were very informative. I'd like to add 2 points. One is that there was a lot of discussion about pipes. However, one of the other modes of smoking is foil, which we have distributed periodically when we can get it in from overseas and get it past customs. It is still probably considered paraphernalia, but it's a special kind of foil. It is not coated tin foil. It is uncoated or not coated. And then the second thing I'd like to just add is that in terms of reaching clientele and participants to get into treatment, in my experience, both in public health and in harm reduction, I have come to the conclusion that there's really 3 major access points. One is your emergency rooms with overdoses. The second is your corrections programs or law enforcement engagement. And then third are your harm reduction sites where you're distributing products that the people want. And I would just bring those 3 up because many of the presentations today centered on things that could relate to 1 or 2 or maybe all 3 of those different means of accessing or sites of accessing people. And with that, I would just like to thank you all and be listening in your meeting in July. Thank you.
Thank you. Appreciate those comments. Anyone else want to speak in public comment?
Yeah, we have one another here in Vegas.
Hi, Attorney
All right,
General.
go ahead.
Hi, this is Dr. Dixon. Want to say something about an update. I don't know how many of you have been kept update with what the DEA has done. And they have, as you know, back in December, they did away with the waiver for having to prescribe buprenorphine. And then they said that in return for not having to do the waiver course anymore, they would have a 8-hour requirement in training for everybody, all of us licensed providers. And so they finally came up with their recommendation this last week. We all got letters from the DEA. And we're also talking, besides doctors and nurse practitioners, PAs, we're also talking podiatrists, dentists, and something, I can never remember what the 6th one is. But anyway, so it's an 8-hour requirement of training that has to be done before you renew your DEA certificate the next time. Now the DEA stretches that over several years, but anyway, so but the first group that it's going to apply to will be renewing, I guess, the end of June, the 1st of July. So they have to start having the training done. Now there's a whole lot, if you look at the letter, there's a whole lot of things that will count, which includes those who've already done the waiver training. That counts, you're done, you're good. And a bunch of boards and all kinds of conferences. But we are working on the poor folks that are still left out of the loop, which is probably many thousands in Nevada, that still are going to need to do this training and get started depending on when their DEA certificate is due to renew. And so I am working with Dr. Havens and the Medical Society and the Psychiatric Association on getting probably stuff that's already online and available, getting it out to most people so that we don't have to try to do some new training. It's really all out there. We just have to get people to know where it is.
Thanks for the information, Dr. Dixon. Dr. Narizi, and then we'll go to Debbie.
This is Alan Narizi for the record. Thanks, Attorney General Ford. Just wanted to make a comment about the buprenorphine. Buprenorphine is still a narcotic, so we have to make sure that we don't make it as very simple, safe solution to what we face. Because one, I'm afraid that again, in 10 years from now, we'll look at what happened to OxyContin. It came as, okay, it's opioid, it's safe to use it. And what we face, the overuse of the medication over time. It's still the focus needs to be opioid is opioid. You have to find an alternative option, and not just to make it as a sort of a pattern to become more use of buprenorphine, because that can still kill the patients. So this is the part that we have to focus more, and that's what I'm seeing more and more about buprenorphine, as if this is a very safe alternative to use instead of the opioid, and wanted to say that's still an opioid.
Thank you. All right, Debbie.
Yeah, just real quick question. Speaking of the DEA, they have, and I don't know if this is part of another meeting of prevention or whatever.
Debbie, I'll have to stop you, Debbie. We won't be able to answer questions in public comment, okay? You can make a comment and you can ask a question and maybe someone can respond offline, but yeah, there's no discussion back and forth in public comment. Sorry. Okay,
so I'll just say, I would love to see the DEA program, the school program, brought back into our state. The 360 was taken away from our state. They now have Operation Engage in 12 states. And that is what I'd really like to see, is them back here. So that's my comment. That's it. But thank you, everybody. Just great presentations today. Thank you.
Thanks, Debbie. Las Vegas.
Thank you, Attorney General Ford. Jessica Johnson for the record. Apropos of nothing, I'd like to invite folks to the May SURG Prevention Subcommittee meeting, where we'll have someone from the DEA talking about their community programs that are happening, at least in California, and what other states are doing. Thank you.
Love it. Thank you so much. Okay. Last chance. Any more for public comment? And we have none received. Okay. Well, very well. Thank you so much, everybody. It has been great to be with you all, and it's been an informative meeting. We will adjourn, and I'll see you in July. Thanks, everybody. Bye-bye.
Thank you.
All right.
Thanks, everyone. Bye.